Hello everyone, my name is Paris Purnell and I work in Global Clinical Education at Hollister Incorporated. With me today is Colleen Drolshagen and Renee Malandrino, both clinical scientists in our Clinical Affairs Department at Hollister Incorporated. Recently they co-authored a journal paper around convexity, just recently published in the WCET journal. And today I'm going to ask them some questions about their experience in this journey developing evidence around convexity and convexity usage for clinical application. I'm just going to ask you, as you're both WOC nurses, thinking back to your various practices, what evidence did you rely upon in making your decisions when you were choosing products?
So thinking to my practice, I relied upon my WCET education, the guidelines, all the material that we learned in class, as well as attending conferences and sitting in all those sessions were fantastic, and my peer-to-peer interactions at conference, as well as the poster interactions, which I had the time to actually talk to authors, which was really exciting. And I had a lot to learn from them at the time.
I would agree with that, Renee. And, we learn so much in our foundation. When we go to wound ostomy content school, we learn the principles and the foundations of what that is to care for those types of patients. And then you take that to your practice, and then you just grow with that and build on that with sharing your practice with your peers, and also getting the clinical experience with that. And I think sometimes it can be very profound on what changes your practice. Sometimes it's not a randomized controlled study, but something that may happen to you personally. And I think of an example of, I took care of a young lady who had a temporary ostomy. She went back to surgery to have the stoma reversed, and she came out of surgery and she ended up having a permanent colostomy, and she was devastated by it. And she went home and she was doing fine. And about 3 months later, she called me up and she was extremely angry with me. And I said, my gosh, why are you so upset? And she said, you never told me about irrigating a colostomy. And she said, I'm a postal carrier and it has changed my life that I had the opportunity to irrigate, but you never discussed it with me. You never told me about it. And I thanked her for her honesty. And that was profound. I made a promise to her. I said, I will never, ever, ever not discuss that again with the patient, because that's really their choice. It's not mine. And it was something that we learned in school, but it was shorter hospital stays. I just forgot about it. So that person changed my practice.
It sounds as well like a lot of the practice changes are based around experience as well. Everything sounds very experiential. So that's why I think when we've got all these layers of experience, how can we do better in terms of basing a lot of our decisions around evidence and what's there to support us with the evidence as well? I think the next question I was going to ask, how important or beneficial do you think it is now to have evidence that supports ostomy care? Because really in the past, traditionally, we've never really had a lot of evidence that supports or guides our decisions. It's usually art versus science in a lot of cases. I'm just wondering what your thoughts are around, there's evidence for practice and supporting change.
I think it's really important that we start building more evidence around real world in the ostomy care. And it helps with just listening to Colleen's conversation and what her experience was. And if we had evidence behind, do we offer irrigation or do we offer convexity? If we had evidence around that, it would be able to have better conversations with our patients, not only amongst us as peers, but also then we bring the evidence back to our patient and help them with better outcomes.
Mm-hmm. I think so too. And I would like to see more evidence embracing the patients when they go home. Because I think if you're an acute care nurse, we know that world really, really well. And we send the patients home with their products, but we have no idea what they're facing on a day-to-day basis. And I had the unique experience because I did do wound care. I also did outpatient and I did acute care. And I feel like I'm a really good teacher and I explain things really, really well. But when I would see them in the outpatient clinic after they can discharge, they sometimes would say, no, I've never met you, even though I spent hours and hours and hours with them. Or, no, you never told me that about this particular product or something like that. So how we interact with them and then inpatient is so much different than when they go home, because they don't remember meeting necessarily an ostomy nurse. They don't remember learning about all the different features of an ostomy pouching system. And oftentimes what you hear is they may call you up on the phone and they'll say, you put me in this pouching system and I must be doing something wrong because it's leaking all the time. When indeed they're not doing anything wrong, it's that they're in the wrong system. So I would like to see us be more supportive once the patient goes home and really put the eyes for the acute care nurse to know what is really happening when they go home.
Yeah, that's a really important point. And I think a lot of the time they also anticipate leakage. Unfortunately, they had this experience in the hospital, and the well-meaning hospital nurse or ward nurse will say, don't worry, it happens all the time. Straight away, that's set them up for failure, because even though it's well-meaning and well-intended, because the nurse is not distressed by it, the patient has this message already that that's normal, that's routine, I should expect leakage. So they go home and they anticipate leakage. We need to flip that coin pretty smart and change the language as well and sort of say, that should not be happening. We should probably get you into a product that's going to work much more with you. And that's where sometimes the convexity conversation can start earlier in that journey for those particular patients. So I think that that's a really important part. Do you think right now, with the evidence that we have or that's being generated as we've seen in this supplement, you guys have pulled together lots of different facets of evidence. Do you think that that's going to help make more informed decisions around clinical applications for using convexity earlier in the journey, particularly in that transition period that you mentioned as well, getting them home? Is that something that's going to help drive change? Is that what you see?
I really hope so. I really, really hope so. A lot of our data that we found and through our research has shown we should start convexity earlier in the journey. This way we can get people started on it, understand where they are. And as their stoma goes down over the next 6 to 8 weeks, they need that convexity. I think it's really important that we continue that.
Yeah, and I don't know, Paris, it's kind of mind-boggling when you have the plethora of evidence that we have. Why wouldn't you put somebody in soft convexity? I think of the patient that has an ostomy. What's their two biggest fears? Is that they're going to smell and that they're going to leak. I started using convexity way back in like 2014, 2015, because I thought to myself, why would I allow a patient to leak when I know that they're going to get a better fit? I didn't really concern myself too much about mucocutaneous separation, because lots of times if they're going to separate, they're going to separate. And there's nothing I can do about it, because they might have been on steroid therapy. It could be the stomach construction. Could be that their body habitus puts them at risk. So, and if it separates, I'm a wound care nurse. I know how to heal that. They're going to heal. But leakage and periostomal skin breakdown, that's an issue. That's a whole other issue. So I don't know. It's kind of mind-boggling why something would be resistant.
Yeah, you really want to get much more proactive in terms of prescribing. And I know that that's been a big boogeyman in the myths out there around convexity causing mucocutaneous separation. I think that's probably one of the greatest hesitancies that people have. Going back to the evidence and talking about the evidence, sometimes it's very powerful and something that's going to make you change very quickly, like your irrigation story that you mentioned earlier.
Yeah.
But sometimes you can have empirical data or a randomized control trial and you'll show it to a clinician and they're still not, no, I'm not doing it because that's not my experience. I'm just wondering what kind of evidence, thinking that through a little bit, would really help compel them to think, maybe I should start thinking a little bit more about doing this earlier in the journey rather than delaying it. Is there anything you could think of enhancing them to be more proactive?
Well, personally, I'm very proactive after listening to Rosemary Hill's presentation at WCET a couple of years ago. That was very impactful to me. She made such a difference with even a small sample size. And she was able to convince her surgeons to do it in the OR, which was very impactful to me. Again, she was very proactive and her urostomy patients did not leak. That made a big difference to me. And I think we should be trying to do more of that research. And it's going to save nurses time. One of our surveys we have, it talks about nurses deal with PSCs 50% of their nursing time. Wouldn't that be fantastic if we can avoid that leakage prior in the hospital setting? And to me, I think we should try soft convexity.
So having other clinicians who are in the zone, in the field, in the front line, so to speak, really making the change. But what I love about the Rosemary Hill story is that she made her change based on all the evidence. She'd seen a lot, she'd heard a lot of people presenting. She's like, hey, a minute, maybe I can make a change. Why am I doing it the old way, so to speak? So I think that that's evidence that has now generated more evidence. So that's really powerful. And I think that peer-to-peer experience is really important. So I think that's something we could do more of.
I think the peer-to-peer is really, really impactful, very impactful. And as stoma care nurses, especially working in the acute care setting or home care or extended care, whatever setting you're in, you're so busy. And sometimes it's easier to just keep doing what you're doing than to try to take the time to bring about change, because it's time consuming. Like I think about, going to the value analysis committee and saying, I want to bring this product in. You have to show the evidence that why I want to make this change. If it's going to cost more, you have to justify that, get this product on all the units, and I have to coordinate the education. So I think that can be sometimes a stumbling block for some nurses. But when you think about the outcome of it, it is really, really impactful. Just managing PSCs. The time that the nurses in the hospital are managing PSCs because of leakage, it's crazy.
When I was a WCN in the hospital, I did exactly that. I set up a research study. I pulled data in order to manage, it was hospital-acquired pressure ulcers at the time. And then we looked at the data before for 3 months, and we saw the high level of hospital-acquired pressure ulcers. And then we instituted an intervention for every ortho patient that went in for a hip surgery. We put a sacral dressing on for every single patient. We were able to say by the end of that research study, we had 0. We were able to change practice in the hospital so that anybody that had a surgery longer than 2 hours in the hospital, they had an intervention to prevent a hospital-acquired pressure ulcer. That is the way I look at Rosemary Hill's data, because I feel like she had a problem. She saw what was happening to her urostomy patients. She went into the OR. She heard about convexity, soft convexity, and she instituted that. So I find that as WOCNs, we have such a strong research tool that we can utilize, even if we have to ask for help.
I got rid of anti-embolism stockings at our hospital because we had many people that developed necrotic heels. We had a few patients that actually ended up with an amputation because they should not have been placed in the anti-embolism stockings. And so I went before the medical committee and I showed them pictures of people's feet from misuse of the anti-embolism stockings. I made a huge difference for a lot of people. So instead of the compression stockings, they went with the sequential pumps to prevent embolism.
Yeah. No, I love that. It's all really great stories where it's so powerful to get evidence that then empowers you to make that change. And we talked about, and Rosemary's exactly said that in her articles as well, it's how difficult it is to make that change, institute that change, and then have it stick as well is also part and parcel of the whole thing. So I think that translating that evidence into practice is really important. I think one of the other questions was when, there's lots of different pieces of evidence in particularly your section of this article, which is great. You've pulled together so many bits and pieces of real data that shows significant impacts when you're using convexity, whether it's reduction in PSCs, etc. Obviously a reduction in leakage, better quality of life and things like that. I'm just wondering what you think might be, next opportunities for evidence generation in this area in particular.
I would love to see more WOCNs stand up and, or at least an ostomy nurse, stand up and let's try it. Try it in your hospital and set it up as a research study, because it just makes all this evidence stronger.
It'd be interesting to do a study where the stoma care nurse is really adamant that I'm going to just keep using flat. And just for the opportunity, like you said, let's just try it on 10 people and see, do prospectively, look at your leakage rate. Then, okay, stop. Now we're going to try this soft convexity and see if it's dramatically different. I would guess it would be.
Well, see, now my turn to tell a story, and I'm going to toot the Australians' horns. Based on the Rosemary Hill paper as well, people have been questioning why we're doing this. So there's one place in Australia that's going to start their trial. Then they're doing their ethics at the moment, that they've recruited several other hospitals. So it's going to be a multi-site trial of using convexity earlier in the journey, placing it on the patients in the operating room and then following through. Because currently 100% of their patients are being discharged on soft convex now. So it's kind of like, why?
In Australia?
At this particular hospital, but within Australia, though, it's easily around about 80% of all discharges are going on convexity in some way or another. We're very used to using a lot of convexity there, but the earlier part in the journey, like right in the post-operative phase or in the operating room, that's relatively new concept for us. So that's something that's happening. So lots more evidence to be generated there as well. I think that one thing that I think would be really helpful would be more data on mucocutaneous separation. It's the boogeyman out there as to, what could be really impactful. And I think that that's one of the key things for evidence in the future where we can make an aha with some of these clinicians who are resistant to using convexity early in the journey because of the fears of mucocutaneous separation, even though the literature says this.
No,
And it supports that.
no, right?
So this is one of those things that has been handed down from generation to generation, so to speak. So do you think of any other opportunities that might, in terms of evidence that might really help propel that conversation?
Another area that I think we should be gathering more evidence is in home care, for sure, just to see the success rate of soft convexity usage in the home care. Because when somebody goes home, which we all know this, 6 to 8 weeks, the stomas go down to the right, at least normal size or their size, and their lives start. Their bowels start, their activities start, they're taking their children where they need to take them or activities. It would be really great to see them not be dealing with leakage.
Decreased PSCs, I would imagine, improved quality of life, because we highlighted one of the articles written by Laura McNichol and Yuri on the more severe the PSCs, the decrease their quality of life. And, again, we're there to support and try to ease that journey of adapting to and of living with an ostomy. This having soft convexity, decreasing leakage, decreasing PSCs, and improving quality of life would certainly help. So I agree with you. Really, the home care arena and knowing what's really happening out there. Because lots of times, if someone's being followed in home care, at least it's this way in the United States, is oftentimes a home care nurse is not a WOC nurse or a stoma care nurse. They're more of a generalist. They go to one house to do diabetic teaching. They go to the next house to do cardiac teaching. And they go to the next house to do wound care. They go to the next house to do ostomy care. That's not to belittle the home care nurse. I mean, they really do a great job, but they don't have the expertise that a stoma care nurse does. So they're going to put the patient in a product that they're familiar with or that their home care agency carries and may not necessarily be the right product. So if we have an opportunity to change that practice, that would be wonderful.
Yeah, that's a really hard one because I think a lot of countries, again, that's when the wheels fall off, so to speak, when patients go home because they're more active, everything changes, the environment changes, and then there's just this lack of follow through and there's really no specialized stoma care nurses in the community. They're jack of all trades, to your point. They do everything else and then it's so low on their educational radar. That's where we think, again, maybe if patients are getting home on convexity earlier in their journey, they're going to have better outcomes. It's almost like an insurance policy.
Right.
When they get there, that they're not going to leak.
And that's exactly what happened to me. I was getting ready to discharge a patient. And first it was on a flat system. And I said to myself, I know eventually they're going to need convexity. And I thought, why am I going to send this person home when I know that they're going to need convexity? And that was the first time I made that change. And then I followed up with them 2 or 3 weeks later and they had no leakage. I'm like, oh my gosh. And I think it was a urostomy patient, actually. And I also found, to support Rosemary Hill's work, they would be beautifully constructed stomas on flat abdomens. But yet when I would take the pouching system off, I could tell that they were still leaking. So that was my first group of patients that I started using convexity on.
Yeah, and I think that goes back to the other consensus statements around convexity and liquid output.
Yeah.
I think that evidence is also very compelling. If you put liquid output, you should be in convexity.
Right.
It's sort of like, it's pretty easy now in some respects.
I would like to confess, when I was in practice, I used to order from Secure Start or other companies' discharge programs. I used to order convexity to make sure that they would get those samples at home because I was always thinking that the home care nurse is going to walk in their house and they're going to be leaking and they need a convex barrier. So I absolutely sent them home with convexity too.
Yeah.
So it's like curveball with the materials that you all put together, because there was several sources of data that you were pulling in for this convexity evidence. Anything struck out as an aha moment for you? It's kind of like, secondary maybe to even Rosemary Hill, but that was just kind of like, wow, that's really a powerful piece of data that really reflects what's going on in terms of convexity. Does anything ring a bell?
There was 4 patient surveys and it was over 10 countries. And on 2 of the product surveys, they used the DET tool. That's that validated, reliable tool that will rate your peristomal skin. And of those, it was significant improvement on those that they converted to soft convexity in terms of their PSCs. That's remarkable. I think that's just amazing. And this was a big group of people. It was global. A lot of people enrolled in the pod.
And what's interesting about that one as well, that's retrospective. Imagine the outcomes if they'd started his stats earlier in the journey. So I think that really tells a really good story about being proactive on discharge.
Right.
Getting convexity on earlier in the journey.
I used to always say leakage trumps mucocutaneous separation.
So I just always said leakage wins.
Yeah, leakage wins.
No matter what you do, you've got to fix the leakage. I don't care what's there, you just got to fix the leakage. So leakage beats everything. Fix that and then you will figure out the rest.
Right. It's
Kind of thing. Otherwise,
totally agree.
more leakage you get, the more danger of a peristellar skin complication, and then it's harder to fix. So then you get this really bad cycle of trying to fix all these things, and it just gets worse and worse.
And to that point, when the stoma care nurse isn't there in the hospital and it's the patient starts to leak, you want to be able to give the nurses at the bedside the right products to treat the patient and either prevent the leak or address if a leak is occurring. And there's so many different products. If you had one or two options only available, most oftentimes the soft convex is going to be the easiest thing to do to address the leak. When I was in practice, it was an exception to order the soft convex. If I was doing my practice now, I just have soft convex and have the flat products be it kind of an outlier. Yeah, for someone that had a really firm abdomen or something like that, where soft convex, you would not really address the issue.
I just want to add here is when we were writing this article, it was so fascinating that we could all see, the five of us, we could see the evidence building to get us to the point of Rosemary Hill's research that we should be doing more of that type of evidence generation, where now it's time to do more real world, because all these surveys, all the evidence points to the right thing.
That's a really good point.
And I think the surgeon in the operating room, I think they would be perfectly fine. I don't really think they think too much about what goes on in the abdomen when they're constructing their stoma. So I just refer back to my own practice. If I went and asked the surgeon, can we use this barrier versus a flat one, they'd be like, yeah, whatever's going to give the best outcome.
Yeah.
Yeah. I don't really even think they think about mucocutaneous separation.
Yeah, I've spoken to a couple of surgeons. They've pretty much said it's negligible. If you think that's going to work, put it on, kind of thing. So most of the colorectal surgeons say that mucocutaneous junction is pretty strong. And again, to your point earlier, if they're going to separate, they're going to separate.
They are.
There's nothing you can do about it. And there is some interesting potential studies as well showing that, using that convexity earlier can actually help shape and secure that mucocutaneous junction or support it even better. So while that's anecdotal, it just feels like that's an opportunity for research in the future, again, for using convexity earlier, because it's starting to show that you can actually reduce the impacts of mucocutaneous separation as well. So I think there's lots of opportunities from far more evidence generation, and another article from you guys.
Yeah, absolutely. Yeah.
When you're out and about and you're talking to the nurses' peers, what are some of the arguments for not using it? What are some of the limitations or barriers for them?
I will speak to the countries that I'm very familiar with. The main ones have been mucocutaneous separation. That's been the main one, and potentially pressure effects. I do hear in other countries cost. It costs more, but in the long run, it costs less. But they look at the initial cost versus the running costs.
Yep.
And then the use of accessories or anything else like that. So that's one of the other ones. The other thing is potentially, I know some hospitals don't like to stock additional sizes because, as we know, with the characteristics that we've talked about, you sometimes want your plateau to be that little bit closer or further away, depending on your patient's assessment. That's holding excess stock at specific hospitals. But I have some other countries where that's not an issue. Product is essentially free. They just order it and they get it. So it's not really them holding it. It's additional stock. So it's so variable by country. One thing I was going to ask you was specific to the US, because I did mention Australia, but also Japan and New Zealand are very high propensity users of convexity. Again, 80% of the time. So flat's kind of almost on the way out. I'm just wondering, in the US, are you seeing that starting to move, or is that still being held back for any specific reasons?
We've been talking about soft convexity use at our conferences for the last 4 or 5 years. So it's kind of shocking to me that that we don't have 80% like you do in Australia and Japan.
I think if we could convince people post-operatively to start it there, I think that's basically our avenue. But in the U.S., a lot of our hospitals need post-op kits, right? Infection control and things like that. And then you don't have the ostomy nurse in the OR to help with convexity. So I think it's a learning curve. I think it's just going to take time and more diligence by the nurses, the ostomy nurses specifically, to bring it into their institutions to start the patients earlier.
The argument about cost, which is interesting to me because if you're leaking, think about the cost of treating that PSC and then the cost of the frequent pouch changes.
I think one of the other costs, it's the emotional cost on the patient. There's a piece of data that actually has shown that one leak on a person's clothing has the ability to last in their memory for 1 year. So that's one single leak. Leakage for a patient is catastrophic. We have to stop that. Leakage wins. We have to stop that at all costs. It's profoundly effective.
And I like to share part of we do a longitudinal ostomy registry study, and there's a theme in there that people think it's okay to live with peristomal skin complications. It's their way of life. They know it's there. They know it's going to happen. That's a big thing we need to change for them because leakage is horrific. Honestly, the damage.
And with some of the clinical studies that you and I have done, Renee, we help them take their pouching system off and they have obviously leakage and they think that that's normal.
Right.
They think, well, because I have an ostomy, and it's also normal to have peristomal skin complication, just like you said. And no, it's not normal to leak and it's not normal to have complication.
I think childhood, sometimes you rip a Band-Aid off and you lose a bit of skin with it. You just anticipate that you're going to have this problem because you're taking an adhesive off. So they expect to have a problem. And so even as much as you teach them in the hospital, they forget because they've got a million other things going on in their minds as well. So it's quite fascinating. But yeah, if we can really finish off with sort of getting that leakage addressed from the get-go so that it's not an issue, but also changing the language around that in that, no, leakage should not be happening. Not like, oh, it happens all the time. Leakage should not be happening. Let's fix that. And so having them getting to a more proactive approach in terms of doing that. And I think that's really important for our clinicians to understand that as well.
Yeah. And I think, as clinical scientists and also as practicing stoma care nurses, we have the obligation to move our science forward. We have the obligation to get the message out there. So I'm so proud of this supplement because I think it's helping me reinforce what we already know.
It's all about evidence-based practice. So I think that's really, really critical. With that, I really like to thank you for both, contributing today and having a great conversation. Your article is going to be fantastic. It's well received already and it's only just out. So I want to say thank you for all your efforts in driving evidence and helping shape clinicians' practices in the future. So thank you so much for your time today.
Absolutely. And thank you for inviting us.
Thank you very much. We appreciate it.